have this much of papers.
Sir, please
Yes,
start your session. Over to you, sir.
Thank you. Hello, good afternoon, doctors. We
Good
cordially
afternoon,
invite
good afternoon,
you
sir. Good afternoon.
to this
Good afternoon.
webinar on the role of Oseltamivir in flu management. Doctors, this program is brought by Heathrow Healthcare, which is an innovative pharmaceutical company. Our journey began in 1993. We have 30 plus years of excellence and 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, API, and FDFs in the world. Heathrow Healthcare provides 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. We pioneer in quality and innovation, and we have the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, the pioneer Heathrow Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which they received Award of Pharma Excellence in August 2020 for COVID drugs. Today's webinar, role of Oseltamivir in flu management. We have got Dr. Prakash Vaidya with us as moderator. Welcome, sir. And Dr. Anil M.U. and Dr. Somashekar as panelist speaker. Welcome, sir. Dr. Prakash Vaidya, as we know, is MD DCH Diploma in Pediatric Sleep Medicine, GCI from University of Colorado. Attached to Fortis Hospital, Mumbai, and Child Health Clinic, Mumbai. Sir is senior pediatrician with special interest in pediatric pulmonology. Dr. Vaidya is Joint National Convener, Asthma Training Module, Revision 21-22, Co-Convener and Writing Committee member of Under 5 Users Module of IAP, Writing Committee member of Writing Antimicrobials Responsibly Module of IAP, National Trainer for IAP, NTEP, TB Module, NRC, CUF Module, etc. Sir has many presentations as faculty at IAP and other platforms. Dr. Vaidya is past president of IAP Thane branch and has 5 index publications, 1 textbook chapter. Welcome, Dr. Prakash Vaidya. Welcome, sir. Professor Dr. Somashekar A.R. Sir is Professor Ramaya Medical College, Pediatric Pulmonologist and Adolescent Care Specialist, President IIP State Respiratory Chapter 2015-16, Treasurer IIP Allergy Chapter 2015, IIP State Allergy Chapter, Joint Secretary IIP Bangalore 2016, Secretary AHA 2016-17, EB Central IIP Respiratory Chapter, EB Central IIP 2015-2017, Secretary IIP State Allergy Chapter 2021, Chief Editor Pulmoscan, Chief Executive Editor Journal of Pediatric Pulmonology, EB National Respiratory Chapter 2023, Secretary Environment Chapter of Child Health Group IIP 2023-24, President IIP Bengaluru 2024. Sorry. Just a minute. Dr. Anil M.U. Sir is MBBS MD Pediatrics, Fellowship in Pediatric Critical Care DAA, Diploma in Allergy and Asthma, Lead Consultant Pediatrics and Pediatric Critical Care, Spurs Hospital, Bengaluru. With this brief introduction, I hand over the session to Dr. Prakash Vaidya. Over to you, sir.
Thank you very much, Dr. Prashant. I'll be just sharing my screen. Is it visible now?
Yes, sir. Yes, sir. Very much visible.
Thank you very much for this opportunity, and I welcome my panelists, Dr. Somashekar and Dr. Anil, both of whom are very well-known pediatricians from Bangalore, both very big experts in their own right. Dr. Anil is an intensivist at Sparsh Hospital, and Dr. Somashekar is very well-known in all the IIP platforms. He has a very large stellar achievements to his credit. So before I actually before I get my panelists into the picture, I'll just take a few minutes to set the ball rolling by talking some foundation facts about flu and oseltamivir. I'm sure we all know it, but this is just a quick revision over a few minutes. So something about the virus, something about the clinical picture of flu, and something about the molecule oseltamivir. Now we know that flu viruses contain a single-stranded RNA, and there are 3 types, A, B, and C. And A and B cause annual epidemics, and we are in the midst of one right now. And C is a less common disease with fewer symptoms. So how do you distinguish between A, B, and C? That's done on the basis of the internal nucleoprotein and the M1 matrix. And the subtypes are decided by the HA and the NA, that is the surface antigens which are there on the virus, that is in A virus specifically. So our discussion mainly consists of the A virus because that is really epidemic. We are having a huge surge of H1N1 and H3N2, more commonly H3N2. But I have had neither of these two and a different virus altogether in some of the reports. So, so this is the basic electron microscope of the influenza virus with the HA and the neuraminidase on the surface. So what are the usefulness of these two, basically these two targets? They are the target for antiviral drugs and they are also the antigens to which antibodies can be raised. So today, as of March 2024, as per WHO, influenza A viruses circulating in humans are subtype H1N1 and H3N2. B are not classified as subtypes, but there are two lineages, B Yamagata and B Victoria. Anyway, let's not go too much into theory. Let's look at the symptoms of flu, and we are all very familiar of a typical child who comes with fever, headache, myalgia, cough, rhinitis, ocular symptoms. There are so many non-specific symptoms that we call it an ILI commonly, influenza-like illness. So it's something like the common cold, but much worse. But as you know, from patient to patient, severity is subjective and very inconsistent. So essentially, flu is a multi-system illness. So you'll get headache, nasopharyngeal symptoms, systemic symptoms of high-grade fever, muscular symptoms of tiredness, joint pain, sometimes diarrhea, vomiting, and the duration can go between 2 and 7 days. So yes, many times we do need drugs. So I'll tell you in short a little bit about the drugs that we use. So essentially we use neuraminidase inhibitors, which prevent the release of virions from the host cell. Now the commonest neuraminidase inhibitors that we are using is Oseltamivir. And the other class is an adamantane drugs, which we will not talk about because there is widespread resistance and these are no longer used. So what is being used today is Oseltamivir, that is the neuraminidase inhibitor. But there are others like Peramivir, Zanimivir, Laninamivir, but these are not available in our country. And neither is Baloxavir, which is the newest antiviral with a different mechanism of action than the neuraminidase inhibitor. So with this short summary, we will straight away go into our presentation and go into the discussions about all this. And as practicing pediatricians, we want to know the practical aspects, which our two experts will tell us when to use it, how to use it, when not to use it, and all that. The first time Oseltamivir was approved was in 1999 by the US. It was the first oral neuraminidase inhibitor. It is a selective inhibitor of neuraminidase enzyme of the influenza viruses, both A and B. And it prevents virus replication and pathogenicity. It prevents new virions from being produced and it therefore it halts the virus in its tracks. So with this little foundation, some foundation facts, I will now go into some of the flu cases and then I'll get the experts to answer our questions. So let me look at a common case of a 2-year-old boy who has got high-grade fever, cough, cold, interfebrile active initially, but now on day 3 or day 4, he's become very lethargic. His intake is poor. He has some dehydration. Clinically, it is an influenza-like illness. And because the child is very dull and lethargic, we have admitted the child to hospital. So, Dr. Somshekhar, what is the differential diagnosis of this influenza-like illness? Can you shed some light on this, please?
Actually, it's a very good question. And first of all, I thank organizer for this wonderful opportunity for the current science and epidemic is going on. And I sincerely thank Dr. Vaidya sir and his Dan of Pediatrics and myself and Anil are we're very fortunate to be part of this. The question is very important. Is like DD for ILA is very difficult because we know it's a season. The epidemic is going on and majority are viral illness. The question is we are getting sometime like RSV like virus or paramyxovirus. They do different, they behave like a different way. Some if you take paramyxovirus, behave like a bacterial infection also. Or we can take parainfluenzas are there, rhinoviruses are there, adenovirus infections are there. These are all similar symptoms. But here the question, this child was was stable for 2-3 days. Later, he became toxic and dehydrated. With the present clinical picture, what we understood over a period of time, we can think of possibility of influenza, and we can go ahead with whatever the further evaluation.
Dr. Anil, we were in the midst of a very big dengue epidemic also in Mumbai. And we used to find initially that there used to be some overlap between the symptoms of dengue as well as H1N1 flu. What is your comment on this?
So yes, sir, definitely. First of all, I'd like to thank the organizers, thank Vaidya sir also for this opportunity. Yes, as you rightly told, right now we are going through this. Even in Bangalore, we are going through this right now. There is a huge epidemic of flu season, and in between, the dengue is not huge this time around, but we do get cases of dengue in between. So on day 1, day 2, day 3, it becomes difficult in a busy OPD kind of a setup when children are presenting with this kind of a symptoms. It becomes little difficult, but probably little careful history evaluation, having a high suspicion to think about dengue can kind of save us many a times. Yes, as we know, influenza like kind of illnesses, they present with fever, cold, cough. Dengue also, it comes with a severe myalgia, body pain, what we know as a breakbone fever. They have a severe headache, backaches, and these kind of things. Conjunctival congestion is one thing again that we kind of look at. Flu-like illnesses or ILI usually come with kind of a burning sensation that happens in the eyes, whereas this kind of a thing is missing in case of a dengue fever. But we do get conjunctival congestion also in cases of dengue.
We were initially taught that dengue was absolutely a a fever. There was no catarrh at all. But of late, we have seen that catarrhal symptoms are also there sometimes in dengue. So maybe, as Dr. Anil said, it is sometimes, I mean, I think all of us may agree that it is sometimes difficult to clinically distinguish dengue from flu. So is it, I think I often like to rule out dengue before I start on Oseltamivir if the picture is not clear. Would the two of you agree?
Definitely.
If we have a proven case of flu in the family, there are cases we say that adults fell sick, then the children are down, and then there are people who have recovered with just supportive care. We can still think of a flu-like illness, but if it's already into category B, where they're sick enough to get admitted, it's always worthwhile to screen them for dengue fever.
Right. So I think our challenge starts with first distinguishing from other viruses and distinguishing it flu from non-flu RTIs. So what would you say, Dr. Somshekhar, are the red flag signs in a child? When would you want to admit a child and what are the red flag signs in this?
See, one is about if you take severe influenza, we know they'll have respiratory issues and uncontrolled fever, some GA upset, non-respiratory, all those things will be there and it will go far. But here there is no respiratory distress or anything. They'll be toxic. But when it comes to red flag sign, we should think of if it's a tachypnea is there, definitely think of it. Chest retraction and associated, accessory muscles are being active. Take care of it. Hypoxia, be considered because of fourth vital. Dehydration, give a lot of importance because the third day they'll have high fever and dehydration. They'll give a classical picture of dehydration, decreased activity.
Yes.
And if they progress further, they'll have altered status also.
I completely agree with you. For me, the telltale sign has been that the child comes with fever, maybe active for a while, and typically, as per this whole case story, he becomes lethargic on day 3, day 4 with poor intake. And that actually tells us it's a little dangerous situation and it could be a flu and we may need to admit such a child.
Yes.
So, Dr. Anil, what treatment would you start in this patient?
Sir, in this case, awaiting the influenza swab, I know it's your next question. Awaiting the swab, we will just go ahead and start this child on Oseltamivir.
Yeah. So,
and also as much as the definitive treatment is important, the supportive care, I can't stress upon much about the supportive care. Just rehydrating them, taking care of the fever, and just good supportive care is as important as giving the Oseltamivir.
Absolutely, maintaining the hydration and treating any possible hypoxia as well as taking care of the pathogen by doing Oseltamivir upfront without waiting for the flu swab reports. I think the turnaround time mostly in most of the metros is less than 12 hours. Do you get your report in 12 to 24 hours for the flu report?
24
Yes,
hours.
sir. Yes.
Yeah. So I think I completely agree that we do not need to wait for the report. If there is a clinical suspicion of ILI in a sick child, we are going to start. So severe influenza, as per the new guidelines, is defined as he already mentioned, sepsis, shock, severe pneumonia, ARDS, multi-organ failure. Flu is known to cause any or all of these problems. So let me take now one more child. This is a child which is very similar to my first case. This is 18-month-old child with past history of febrile seizure. Fever on day 2 brought with another febrile seizure. So he had a febrile seizure second time, but by the time he came to the clinic, he was quite active, playful. So he was sent home. Now he comes back to the clinic with another febrile seizure, and this time we admitted the child. Now, in this kind of child with a respiratory symptom who requires to be admitted, would you both give oseltamivir here upfront?
See, this child, I think second time had a febrile conversion and respiratory issues also there, right?
Yes.
Okay, worth I think. If you think of epidemic, clinical
So
picture,
in a situation where in the clinical context of flu epidemic, you will definitely give
Yes,
oseltamivir.
better.
yes, sir.
Because
Uh,
what I didn't tell you was that this child had a third episode. He was admitted for the third episode, but in
Oh.
half an hour, he again became active and playful. So it wasn't by definition a severe flu. So here we come to a gray area. Will we give oseltamivir or we will not? So I think Dr. Somashekar is favoring giving. What do you think, Dr. Anil?
Yes, sir. If the child becomes active, playful, and as per the ILI guidelines, if it is category A, B, and C, if
Yes.
someone is in category B who requires to be admitted for further management, I think
Right.
anyone in the category B and above getting admission, we would treat with oseltamivir.
This was a little gray area because he was admitted not for the severity of flu, but for the seizure. So,
Yes.
of course, I think I would also agree with both of you and give benefit of the doubt here. Now, this was the report of the child with influenza B not detected. I don't know if it's visible. Here they detected influenza A, but somehow the report did not detect either H3N2 or H1N1. So just as an interesting aside, do you ever see such reports which is non-H3N2, non-H1N1
Yes,
in
sir.
Bangalore?
We do come across such reports, and such a case by case definition probably we would classify as probable influenza, probable flu.
Yeah.
Where subtyping is not possible, but influenza A is detected positive.
Yeah.
This is definitely a probable influenza, and with the background of this epidemic that's going on, definitely it's worthwhile to treat this child with the oseltamivir here.
Absolutely.
And
Thank you.
I would just add on to this because I'm just had a child who had come similarly with 2 days of febrile illness, had a seizure, recovered, but with the second seizure became comatose. The GCS was down to almost 8.
Okay.
And then when we investigated, we had the most terrible complications of the influenza, the CNS complication. Initially, we were thinking it's an encephalopathy, but when we did a MRI, what we got to know was this child had ANEC. That is, both the thalamus was lighting up. So acute necrotizing encephalitis, this child went through a long recovery period and is still undergoing rehabilitation. So
Thank you for
always,
that. Yeah, Dr. Anil. I mean, that's a good reminder that flu is not just respiratory, but it can be involving the CNS, and we'll come to a case of that. But
I'll just one small shot, like how Anil said.
yeah.
We had a 3-year-old child and recently detected as an nephrotic syndrome, just a proteinuria, being evaluated. Morning, baby had fever. By evening, went into shock, encephalopathy, all the picture cascade, and finally recovered. But somehow, high index of suspicion made us to think of, that seasonal pandemic and started treatment.
Right.
Of course, it was positive for H1N1 also.
I think we have a problem here is that we do not have a standardized test in the CSF to detect the influenza virus. The biofire does not detect it. Dr. Anil, do you agree? I mean, how do you detect the influenza virus in the CSF?
that was through the nasopharyngeal swab itself.
So we have to do the nasopharyngeal. We cannot detect it directly in the CSF because the biofire does not include influenza for some reason.
Yes.
Okay. So we'll come back to CNS in a while again because I do have a case. But while we are on the same child, now this same child was admitted because of lethargy. But suppose one of you had seen him in the OPD and he was active when you saw, and intake was not normal, but it was okay. And he's now on day 3 or 4 of fever. He's passing a good amount of urine. My question to you, Dr. Somashekar, is that in this child, OPD patient, will you start oseltamivir and what are the indications?
See, OPD, the same patient in the previous scenario, He was admitted, even though he was not fitting in, we started. Here is active, passing good amount of air. Here I'll just withhold.
You'll withhold.
Mm.
What about you, Dr. Anil?
Yes, sir. If the child is remaining to be active, that too, if I see them on day 4 of fever and ILI like same symptoms on day 4, child is active, I wouldn't treat him with oseltamivir.
So both our panelists, experts have given a take-home message that do not use oseltamivir right and left just because you think it is viral and because you want to do something. Because now he is on day 4, day 5, is still active, and it is likely that it's a self-limiting illness which will not require the drug. So, who are the children, Dr. Somshekhar and Dr. Anil, both of you may answer this. Who are the kids where you will upfront start oseltamivir when the child falls ill? And I'm referring to who are these high-risk patients where you will not take a chance. So,
See,
yeah.
my background, because I practice little respiratory, I out of the way I'll go if they got multi-trigger wheezer or persistent wheezer or on high-end medication, and which patient with preterm child or they're on a high risk follow-up or immunocompromised state, we just upfront will start, and I'm sure that Anil will highlight some few more indication also.
Yeah.
Anil, some indications from your side?
Yeah, if you go by system wise, like what sir told, it can be a chronic respiratory illnesses, asthma, multi-triggered wheeze, or chronic respiratory issues, cardiac issues. They have a liver condition. They are immunosuppressed for whatever reason. It may be because of hematological conditions. If there is any kind of immunosuppression, yes, we would go ahead and treat them with oseltamivir straight upfront.
Yeah. So I'll just display a table from up to date which tells us which are the conditions which are high risk. With respect, I have a slight disagreement with both of you that I may not take a child who is wheezing as a high risk child, because wheezing is extremely common and children with wheezing are not necessarily sick or immunocompromised. But I think it will depend from case to case. So this was the display from up to date, which talked about underlying conditions. So one of them they have mentioned is asthma, cystic fibrosis, but not necessarily under 5Es. So asthma, cystic fibrosis, BPD, hemodynamically significant like cardiovascular disease, chronic renal disease, chronic liver disease, diabetes, cerebral palsy, neuromuscular disorders, extreme obesity, and as Dr. Anil pointed out, immunosuppression. So any of these cases in your clinic, children who are not otherwise sick, but because they are at high risk to get admitted and get complications, we would start oseltamivir early. So what is the advantage of starting oseltamivir, Dr. Somshekhar?
See, definitely, see, we don't know, we know both the ends of this, the flu pandemic. They recover fast, they deteriorate fast also.
Correct.
When you start this, especially two things, when you have a red flag signs, you identified the patients, you start it, definitely it avoids the further progress. We are mainly focusing on the respiratory complication that will be arrested, or whatever the other systemic complication be avoided. And if he's stable, it will avoid the mean stay of the stay in the hospital or even the inpatient also, as well as in the ICU care. That is, but mainly to avoid the complication we do. That is the thing. And
So,
of course, if there is comorbid condition, that also, it must, and we will be treating both the condition.
so oseltamivir will help you to avoid unnecessary morbidity.
Yes.
It will reduce the viral shedding and it will reduce the hospital stay as well. Okay. So my question to
I just want a question, like, what about obesity? Like, what about, do we see a lot of
this is
obesity
mentioned as BMI
more than
the
40?
95th percentile in
Yeah.
children
Mm.
are
That's a
qualifying
practice.
as high risk patients. Now, this is from up to date, the latest version. So I leave you guys people to decide whether
Just
it's really
because in metro we see a lot of
correct.
obese children.
So
That's
that way
why.
we will have to, widen
Mm.
our
Yeah.
indication a lot.
Sure.
So just now on a day-to-day basis, and already you've talked about when do you give oseltamivir, but when do you decide to withhold oseltamivir in your practice? I mean, when there is a gray area, what makes you decide, I'll withhold it? So I'll just ask one by one to both of you, please.
So
See, we are, yeah, Anil.
sir, please go ahead, sir.
Ilamail, please.
So when to withhold, that's a decision for us to make clinically, probably on case-to-case basis when we see children on OPD. If the child is too well, active, feeding well, very minimal symptoms, yes, we would want to withhold. Even in this kind of an epidemic, we would want to withhold if the child is active, playful, and doing fine, because we know that it's a self-limiting kind of illness.
Absolutely. The key is it's a self-limiting illness. So whenever he is getting better on his own, it's a resolving. Yes, we will withhold. What
We
else?
want to hold it.
Yeah.
Second category of patients, like you told, sir, day 4, day 5, I'm already seeing someone on day 4, day 5 in the OPD, not as admitted patient.
Yes.
In the OPD, I'm seeing someone on day 4, day 5. Things are already getting better. The fever has settled. Things are getting better. I would just counsel the parents, telling that this is self-limiting. Please hold on. Just take care of the hydration for the next couple of days. Things are going to improve. So if you're saying any improving child on day 4, day 5, I would kind of withhold the treatment here.
Perfect. If it's an improving child, you'll withhold. What about Dr. Somashekar? Any
Yeah, if the swab comes negative,
Huh.
I'll just
So
withhold.
before that, I'll ask you a question that how many flu patients on an OPD basis do you do a flu swab? Just as a matter of
Very minimal, very
very-
No,
minimal.
sir. No.
hardly ever,
Hardly
right? So I think all of us are in the same page. We
Yeah.
hardly ever do a flu swab on the OPD basis. We would do it in mostly admitted patients. But having said that, I have started Oseltamivir in a child with flu, suspected ILI, and now the PCR has come negative. What do I do? Should I stop or should I continue?
See, if you comes to negative, if the children's symptoms are better, you stop it. Rule out the other condition. If the differential diagnosis is strong enough, take it out. But if it is negative also, if you have got strong suspicion of the flu-like illness, or if it is an ongoing illness, give a benefit of doubt. Suppose if you got comorbid condition, immunocompromised conditions, give a doubt of benefit so that it will give some different picture.
What about you, Dr. Anil? Do you go follow the same policy?
It's a clinical call, sir. There is no other alternative diagnosis, and everything is fitting into influenza-like illness. Child is sick, I would continue with it. If the child is very active, playful, and things are getting better, probably I'll withhold it. And if I get any alternative diagnosis to explain, I will withhold the Oseltamivir.
So the problem with getting an alternative diagnosis is, I think most of the hospitals, at least in our city, are bundling the flu swab with the RSV. And sometimes I suspect flu and it turns out to be RSV, and then I'm empowered to stop the treatment because I know that I have an alternative diagnosis of RSV here. But suppose I did not have that, then possibly I may need to continue the Oseltamivir even in the face of a negative swab. Is that what we are agreeing on?
Yes, sir. Because of the safety profile of Oseltamivir, I think if we don't have any alternative diagnosis, I think we are justified in continuing it for 5 years.
But however, if your swab comes for some other virus positive and you have a feasible diagnosis, I think I would not continue Oseltamivir and stop it without completing the treatment. Right?
Agreed, sir. Agreed.
Yeah, thank you.
Yes, sir.
So this is again a screen from UpToDate talking about antiviral therapy for children with suspected influenza. And any of the following is an indication for oral Oseltamivir: hospitalization, serious complications, clinical deterioration. Also for children with non-severe illness, Oseltamivir is a molecule of choice. In the later ages, it becomes Baloxavir, but in our country, we don't get Baloxavir. So Oseltamivir is definitely the choice as per WHO as well in non-severe as well as severe illness. Let me take one more case, and I would like you as both practicing pediatricians to give me an answer on this. I have a breastfeeding mother who develops moderate influenza symptoms. Her baby is only 2 weeks old. Her physician has told her to start Oseltamivir, but she asks you, her pediatrician, Doc, is it safe for my baby if I take Oseltamivir? So, Dr. Somashekar, what is your take on this?
It's safe.
So you will.
We can give. We had few cases been seen also, because some papers have mentioned that it is contraindicated, but general population and whatever our gynec colleagues also, we are given, but of course my experience is limited, but it's be given. I think Anil should give me more idea.
What about you, Dr. Anil?
Yes, a mother can definitely take it.
Yeah.
Absolutely no contraindications for it. Because she has already moderate symptoms. It's not even mild symptoms. She has moderate symptoms. I think she should be treated with Oseltamivir.
I would go a step further and say that if the mother is treated, the baby becomes safer from flu.
Yeah, that's what.
Right?
No, here one case was like, after 2 weeks, baby became positive. One of the case. And,
yes. So I think it will protect the baby and
Yeah.
not treat the mother. It's like it's a win-win situation to start
Yes, yes,
Oseltamivir.
yes, yes, yes.
So what is the youngest age to give Oseltamivir, Dr. Somshekar?
The literature says as young as possible, like 3 weeks, 4 weeks they have mentioned.
What about you, Dr.
Our
Anil?
experience is limited.
Two,
Anil,
2 weeks and above is when it is licensed, Oseltamivir, according to the literature,
So
sir.
I saw from up to date, the CDC guidelines were saying 2 weeks,
2 weeks.
but they said that you can give it in neonates if it's a very severe problem. So they have actually said that neonates can also be given if it's severe.
Yeah, that one case I said neonate was positive in our unit. But the question is, of course, it was a mild symptom, but it was admitted in NICU for some other reason.
Mhm.
And of course, it came out.
So now the baby's grandparents are asking that, okay, you're treating the mother. Should we give any preventive medicine to the baby? What is the answer from both of you? Should we give
Prophylaxis is not
prophylaxis to the baby?
recommended for babies less than 3 months of age. The prophylaxis is not recommended.
Right.
And even among the infants less than a year, we would take a call on a case-to-case basis.
Correct. So this case you feel does not qualify for a oseltamivir prophylaxis, right? The
Right,
baby
sir.
doesn't.
Yes, yes.
But
Yes,
the mother
that,
should be encouraged to take oseltamivir in the interest
Yes.
of both of them.
yes.
Okay. So this is what they have mentioned about. So a quick for the audience, a quick summary of the doses I will give you. I'm sure we are all aware and we need to refer sometimes. So below 3 months, it is for treatment 3 milligram per kilogram per dose orally twice daily for 5 days. 3 through 8 months, same 9 to 11, 3.5 milligram per kilogram per day. And even in preterm infants, it is mentioned in certain situations that you can give the dose even 28 through 37 weeks, 1 milligram per kilogram. So there are recommendations for doses in small babies as well as infants as in certain situations. Prophylaxis, however, as Dr. Anil pointed out, not recommended below 3 months, but above 3 months, we do give prophylaxis. We'll come to in a while. Now I'll just come to one more
Even
case.
one simple algorithm was also there from WHO.
Yes, I will.
The office practice, they can use it also.
Yes, I will just come to that algorithm
yeah, sure,
towards the
sure.
end of our discussion.
Yes,
to
sure, sure.
summarize. So this is one more case of a 11-year-old boy, fever, cough, vomiting, cold, altered sensorium. This is what both of you are mentioning, and we do get children with like this. Clinically, query encephalitis, X-ray showed haziness, right lung, intubated in AR, shifted to PICU, lumbar puncture done, CSF normal, started IV antibiotics after sending blood culture, IV antiviral. When I say IV antiviral, of course, I don't mean neuraminidase inhibitors, but antiviral like
Exactly.
acyclovir. And multiplex PCR in the nasopharynx detected influenza A H3. CSF meningitis panel negative, but as I said, it does not detect the virus at all. So this child, if he has come after 3 to 4 days with this picture, would you still start oseltamivir or it's too late?
We would start. So this child is extremely sick. Child is probably on the ventilator, is having an CNS complication, and definitely there is an virus which has been isolated in the nasopharyngeal swab. We would definitely go ahead and treat it.
So I
Even though
think
the
that, yeah,
CNS is usually it's a immune mediated kind of a response that happens in the CNS. So we
right.
don't see a direct viral invasion that happens in the CNS, but
Right.
definitely this case warrants to be treated with oseltamivir.
So I think the take-home message here is that if a child is sick, no matter how late, please give
Yes.
oseltamivir. That is what the guidelines say.
Absolutely. Even fourth day, fifth day also.
Fourth day, fifth day, or
Because
later.
it may give a lot of benefit.
Yes. So in this case, this child was very sick. He developed an AKI, also acute kidney injury, and that is also known in flu. So I think we should all realize that if we don't treat flu at the right time, we are still, I mean, these complications do exist. Viral encephalitis, kidney injury, sepsis, sick, children can get very sick.
Yes.
So my message is from all of us is it is never too late to give oseltamivir. Ideally give within 12 to 24 hours but can be administered more than 48 hours after symptom onset, particularly in hospitalized children and those with serious complications or progressive disease. This is the guideline that comes from the up-to-date. So this is the algorithm that Dr. Somshekar was mentioning, that if it's suspected or I think I have suspected influenza. If it is severe, give antiviral, oseltamivir. if the patient is at high risk of progression, even then you give antiviral. They have mentioned Baloxavir, but here we have to give in India Oseltamivir. And prophylaxis. Now we'll talk about prophylaxis in a little while. So this is a 6-year-old boy. I'll take one more case because I think that makes the points more clear. 6-year-old boy with an influenza-like illness, and he comes to you. He's looking a little sick now. He's getting poor intake, high-grade fever, headache, and you propose that you want to start oseltamivir on day 3 or 4. But the mother objects. She says, "Doctor, you have given him flu vaccine in your clinic 3-4 months back. Why do you want to give oseltamivir now?" So I would like to know on a clinical basis, on a practical basis, how will you react? Dr. Somshekhar, what will you react in this situation?
See, we should tell her, of course, they'll be in the phase that recently been vaccinated and flu has come. We should tell her, we should have a practice, first of all, when you're telling this vaccine meant for this purpose, and it doesn't tell that you will not get the flu-like illness later. Even if he gets, the severity will come down. That we should have a practice. Here also we should reassure that because strains will be different, seasonal pattern will be different. That's how he has got this also.
So I think I'll also tell her first that at best flu vaccine has an efficacy of 70%, which means that 30% of patients who get flu
Yes.
vaccine can still get flu.
Yes.
But would you like to do a flu swab first here to satisfy the parents, or you will still go ahead with oseltamivir? This is just a practical guidance for our audience.
This child it is in the OPD patient.
Yes,
You can
but
just
he's
treat it with.
got severe headache. He's looking a little sick. So that is why we wanted to know whether you will do a swab or you will straight away start oseltamivir. What's your personal perspective on this?
If it requires, I'll not do a swab test. Rather than I'll give the.
Dr. Anil, would you tackle it differently or the same way?
I would start the child in oseltamivir, probably explain the mother regarding the antigenic shift and the drift kind of a pattern. So even though we have given the best flu vaccine which was available when we did the vaccine, there is a slow drift in the antigenic structure of the virus itself. So the current affecting virus may not be the same thing which was there in the flu vaccine that he has received.
Right.
And since things are already into day 3, day 4, he's starting to look sick, I will definitely go ahead and start the child on oseltamivir. And just to convince the mother, if at all she's really wants to be tested, the techie kind of a crowd, yes.
Yes.
I would even ask for a flu swab also.
You
just
put your finger on it. The reason we ask, at least even in corporate hospitals, is why do we ask for so many multiplex PCRs and flu swabs? I think it's mainly because parents they are more happy seeing an objective evidence somehow. So I often do it for that reason, not really because it's going to change the treatment. I'm sure that's the same in Bangalore.
Yes, sir.
Yes.
So here these are the guidelines from up to date. Treatment should be initiated regardless of whether the child has received flu vaccine, should not be delayed to await the results of viral testing. This was in the SARS-CoV time when influenza and COVID were coexisting. So a positive COVID test does not mean there is no influenza, and a positive influenza does not mean there is no COVID. And today this kind of viral co-infection is more true in RSV. I've had number of patients who came positive for both flu and RSV. So one RSV does not rule out flu, flu does not rule out RSV, flu positive. Now we have been talking a lot about oseltamivir use, and I would like to know from both of you as experienced pediatricians, that do you really get adverse effects with oseltamivir, and please share your experience.
See, for my experience, I have not seen much of complications or side effects or anything. Okay, but few patients, they do mention about nausea-like symptoms or anything, but I have not observed any hypersensitive phenomena or anything, and not started with even my experience was PPA also.
Okay, so it is not your policy to start PPI
Yes,
antacids with.
yes.
What about you, Dr. Anil?
Yes, sir. This is the most commonest reported side effect, a little bit of nausea and vomiting following a dose of oseltamivir. This is the most commonest, and usually it's a self-limiting. We reassure them, and I usually do start a PPI in this patient. Who comes back and reports to me with this kind of a nausea, vomiting, I do start. I kind of educate them that this needs to be given only after lunch or after having food later on to reduce these kind of symptoms.
So you started only when the patient
Symptoms.
reports that there is a GI problem.
Right.
not upfront, right?
Not upfront, because already the
Okay.
child is on so many medications. I really
Yes.
wouldn't want to give
So
one.
as an intensivist also, Dr. Anil, you must be aware that we treat PPIs with a hell of a lot of caution nowadays, because we know there's so many side effects associated with PPIs. And in fact, nowadays the current guidelines are warning us against using PPIs, which
Right.
many of us have been using very often. So I think I would also be I would be very be very slow to start a PPI kind of in this case, unless it's really mandatory. So which PPI do you use in your practice?
Ranitidine, sir?
Acha, so you are not using PPIs, right?
Yeah. PPIs, yes. Lansoprazole we do use. Yeah.
Okay. So you use ranitidine or PPI?
Yeah.
I
P-
think
PPA,
PPI, few cases, if they're having hives and all, I
1 day.
prefer to use ranitidine.
Acha, fine. So one more adverse effect of post-marketing has come up in Japan, and they said that there are neuropsychiatric effects, because there they use oseltamivir in a very big way, and they found that some children had delirium, hallucinations, confusion, abnormal behavior. But causality has not been established, and it is also strongly felt that some of the neuropsychiatric adverse events may be related to flu itself and not the drug. This is another common question which many mothers ask me. And the first question they say is that my child is falling ill all the time. So then I tell them, why is he falling ill all the time? Because you, like all other parents, send them to school within 2 days of any illness, and that's how they transmit the virus. So now, what is the right time for a child with flu to go to school? I would like both of you as practicing pediatricians to answer, and how will you tell the parents? And does it make a difference whether oseltamivir is given? Does it mean that he can go to school earlier, or that makes no difference at all?
The guideline says that, first of all, about school business. Now the children's got 1.5 year, 2 years only. They have some play schools and other things. Once again, when they have symptom, because working parents, they'll put them there, and whatever the local epidemic goes on, and that becomes a issue. That as per the policy, they should go after 3.5 years. That's a different story. But once they have a symptom or even taken a medication, they say that prior 2 days or later after the medication of 4 5 days is more than enough to go to school. Of course, it depends on the individual this thing. But if we're taking as a temperature as the criteria, at least 24 to 48 hours, they should be symptom free.
That is exactly what the guidelines are saying.
Yeah.
That CDC says that children with an influenza-like illness stay home or from school or daycare until 24 hours after their fever has resolved without antipyretic. So afebrile for 24 hours. And this recommendation applies regardless of whether the child has received antiviral therapy or not. So I had now one more facet of giving oseltamivir, which I want to emphasize in this, that this was a 10-year-old boy with a presentation on day 2 with fever with rigors. He had a headache. My resident told me that, sir, this child has got follicular tonsillitis, and I am starting this child, that was in the OPD, that I am starting this child on antibiotic. But when I looked up, there were only tonsillar crypts. There was no real follicular tonsillitis. And his blood count was also quite unremarkable, 13,000 with a CRP of 32. And this, again here, because of parental pressure, I'm not sure if this child was admitted, but we did a flu panel, and this came to be flu. So many times we start oseltamivir very rationally, and that way we can avoid giving antibiotics in these children. So my question to both of you is, over your experience, does and diagnosis and giving oseltamivir, has it helped in antimicrobial stewardship? What is your experience, Dr. Somshekhar?
Definitely, especially when you are high dependency areas, this kind of conclusion will demarcate between whether to give the antibiotic or not. Definitely, it helps both to safeguard the oseltamivir as well as the antibiotics. Unnecessary use of
You put your finger on it,
antibiotics.
safeguard both.
Yes.
Dr. Anil, your point
Do,
of view?
Doing a diagnosis using a swab definitely helps us to withhold the antibiotics in the OPD kind of a setting very effectively. We have a diagnosis, we have the natural history of a disease. We can always counsel the parent telling that this is a self-limiting illness, and with treatment, probably the viral load shedding will come down much earlier. Probably 2 days, probably child will be better even before 2 days. So this definitely helps us in maintaining the antimicrobial stewardship here.
So I think it's perfectly, that's my experience as well, that using oseltamivir, diagnosing flu, doing swabs, it all helps us in preventing indiscriminate use of antibiotics, because some people who are not, some people are not ready to wait and then they want to start antibiotics immediately in any fever. I'm sure oseltamivir would definitely reduce the number of antibiotic prescriptions, and that has been found in a study in UK when they found that in the flu season they found that antibiotics did go up, but then when they started using diagnostics and treatment, the same antibiotic, the number of prescriptions really came down significantly. But as Dr. Anil also pointed out, is it that we are going to the other end and using oseltamivir indiscriminately, just 2 to 3 days of fever in a flu season, and we start oseltamivir? Is that risk there, and is there a risk of developing resistance? What is your call?
Definitely, there is with this widespread use of oseltamivir, more so for prophylaxis sake. I think we should be extremely careful when we are treating a patient who is moderately sick to a severely sick. We have absolutely no doubt in treating it. But when it comes to treating the milder cases or using oseltamivir as a prophylaxis indiscriminately, I think this is where a word of caution should go out. Not to use very indiscriminate prophylaxis for a well child and a healthy family without any people with risk factors. Doing a prophylaxis for a very mild illness may not be justified. At the same time, we should not withhold oseltamivir from the ones who deserve it, from the moderate.
Absolutely.
Very important.
Anything
Very
to add,
important.
Dr.
sick
Somsekhar?
children.
Well put. Anything to add?
No. That's what very important.
Yeah, I think we
We
are
should not
we
delay
are
the
in the risk of using too much oseltamivir sometimes, and many people now, even non-qualified doctors are using it on day 3, day 4, day 2, and that can be risky. But yes, definitely oseltamivir has helped us to give antimicrobial stewardship. I'll just quickly talk of one more child. This was an 11-year-old child who came to me last month, fever since 2 days, high grade, difficulty in breathing. And this child was admitted last month with influenza A in another hospital. This time, this child was quite breathless, required HFNC, and she had high-grade fever. She had respiratory infection, and she required. And then actually, she was an undiagnosed asthmatic. She had come to me for the first time, but when I went into the history, it was clearly asthma, but she was never put on ICS previously. Anyway, so the long and short of it is that she was admitted with influenza A, and now this time when we did the swab, it was influenza B and RSV. So the moral of the story is that influenza, having suffered once, we still have to be prophylactic, and sometimes you have to give oseltamivir more than once, even back to back. This was the X-ray of the child. So now I want to discuss one more thing, that you have started oseltamivir. When do you expect a response in a child? When will you say that the oseltamivir has worked, Dr. Anil?
So if the child is not getting better, the interfebrile period, probably the child should start becoming more active, which is not happening. The fevers are not subsiding in 48 hours, and other systems, we should be carefully watching the other systems as to what is happening. If there is some localization to a particular one more system and a constellation of signs and symptoms which are showing that there is something else developing, we should have our antennas up, and that is where we need to go in and step in and start the appropriate antibiotics as well. So especially what we are noticing is children coming back with suppurative otitis medias after starting on a flu. Seemingly they get better, and after say 3 to 4 days, they're coming back to us with a suppurative otitis medias they're coming back with. And if at all there is a lobar kind of a consolidation which starts, and the fever is not subsiding beyond say 48 hours, and when the respiratory signs are not getting better, that is when we need to have our antennas up and start the child on appropriate antibiotics as well.
Thank you. Dr. Somsekhar, what is, in your experience, how long does it take for oseltamivir response to occur?
Usually 48 to 72 hours, it gives a
48
good
to
result.
72 hours is right.
Yes.
At
But
what point do both of you decide that the child requires an additional antibiotic in addition to oseltamivir? On what basis do you decide?
as Anil said, persistent fever, rise counts, if it is localizing to one system, like pneumonia or consultation, or if you are thinking of other system being involved, that is the time we should think of starting an antibiotic. That's important.
Involvement of other systems, and as WHO says that if there is evidence of bacterial co-infection, persistent fever, neutrophilia, possibly a high CRP, possibly evidence of, as you said, a lobar consolidation or spread to some other organ, then yes, you are not going to be happy using oseltamivir alone. But otherwise, using it and getting a response has helped us to use antibiotics more conservatively. Now, the last point I want to say is that when would you think of using oseltamivir for prophylaxis? Now, I'll give you an example. I have a child who was admitted with me. This child is about 3 years, 1.5 years old, had flu. The flu panel also came positive for H3N2. We gave him oseltamivir and supportive treatment, and he is ready to go home on day 3. In 48 hours, the child is fine. Now, my question is that this child is going into a household where there are 2 senior citizens of 75 and 80 years. Should they get prophylactic oseltamivir? One. He is also going, his home also has his younger sibling who is about 4 months old. So I would like a quick answer from both of you on, in this situation, should we give prophylaxis at all?
Extreme measures I do recommend. For
So
grandparents and young
both the
sibling.
grandparents and the younger sibling.
Both are very, vulnerable age group. I think Anil should highlight.
Anyone with risk factors, any healthy adult, probably we can oversee here, but anyone with risk factors, for example, grandparents are there, definitely they do merit oseltamivir prophylaxis. Younger sibling, again, 4 months of age, probably not, because less than 1 year prophylaxis, we are little careful about using oseltamivir in children.
Allowed above 3 months. Hello.
Hello, yes, sir. It's licensed.
Caution we can with a caution.
Yeah. It is. We can use it above 3 months of age,
right,
for prophylaxis.
Yeah.
But probably if the child is fine, we just take the other
This
measures.
is a very practical situation which we face, so I thought we should get a clear answer on that. WHO guidelines on prophylaxis are only for individuals who would have an extremely high risk of hospitalization if they contracted flu. Post-exposure should not be arbitrarily expanded to other patient populations. So definitely not to the parents, possibly for grandparents who are already immunocompromised or who might be having some additional problem like a COPD or a cardiac disease or a diabetes, and of course, very young children with this. Now, I had a child with croup, one of my colleagues, and it grew the PCR. The child was sick, child had high-grade fever, and the PCR grew para-influenza virus. Do you give oseltamivir here?
No, sir, I wouldn't.
Yeah, Dr. Anil?
Yes,
No,
yes.
sir, I wouldn't give.
Oh, sorry.
Oseltamivir.
Not indicated.
Yeah. So I think let's make it very clear. This is only the name. And I saw this child getting oseltamivir, but it is definitely not indicated for the treatment of para-influenza. It is specifically indicated only for influenza A and B. What is the contraindication for oseltamivir? Is there a child where you can't give oseltamivir, Dr. Anil and Dr. Somshekhar then?
Yes, sir. Only if there is a documented hypersensitivity reaction to this oseltamivir, yes, that's a definite contraindication not to give.
Right.
In other cases where there is a compromise, child has a chronic kidney disease, renal functions have to be monitored very well. So in this case, only if it is absolutely required, we would go ahead and give.
I'm just coming to the kidney doses, but there is no, is there any other absolute contraindication, Dr. Anil?
And also hereditary fructose intolerance is one thing where
I see.
We should be very careful and not to use it.
Right. So if the patient has, as they say, enteric antiviral treatment, like he's got malabsorption, delayed bowel opening, or GI bleeding, then you may not be able to give oseltamivir, and peramivir is an option, but it's not available in our country. So I think we have to be, for us, the contraindications are very, very minimal.
Just one question, this egg protein allergy. Egg protein allergy.
Protein is not involved in oseltamivir, right? It's involved in in flu vaccine, no?
Yes, yes.
So are there any?
I was just correlating. That's all.
Right. Are there any drug interactions with oseltamivir that either of you are aware of? Any AKT or anti-epilepsy drugs or any long-term treatment that has a conflict with oseltamivir?
I'm not aware, sir.
Yeah, so even I was looking up, there is simply no conflict with oseltamivir. There is no interaction problem. All they have said is avoid influenza vaccine 2 weeks before or 48 hours after oseltamivir because it may interfere with the antibody response. And regarding the kidney disease, as Dr. Somshekhar has pointed out, in a renal patient, in a child with acute kidney injury or with renal insufficiency, your dose of oseltamivir has to be altered. You'll have to give a lower dose, and I think you'll have to go by the guidelines based on the creatinine clearance. Also, there is no contraindication with acute liver disease or chronic liver disease. It can be given safely in children with liver disease. I think
There is a raised enzymes are there. We know it is raised enzymes are there with the flu-like illness.
right.
During that time, can we give?
I mean, there is no contraindication mentioned about liver disease. So
Yes.
maybe I would
Just closely watch and give, I think.
absolutely.
Yeah.
So I think we had wonderful comments from both our expert panelists, and I think we have covered as much as possible on oseltamivir, all its facets, when to use, when not to use it sparingly, what is the situation where we use it, when to stop, when to use in prophylaxis, and if there are, I think we have tried to cover the entire canvas of oseltamivir. So to sum up, it's a very useful drug, oseltamivir. PCR is not a must. Doing a flu swab, use it timely and use it wisely, and do not use indiscriminately because we do not want it to then have too much resistance developing to it. And I'm sure that once we are familiar with the oseltamivir and the way it works, as well as the implications, I think most of us will be able to rationally use oseltamivir when required, use it when necessary, and do not use it indiscriminately. With that, I will stop sharing my screen. And
Sir, thank you very much. There's one question from audience.
yes.
Does the person to be vaccinated have an allergy to the ingredient of the vaccine?
Mm-hmm. Would one of you like to take it up?
Sir, you take it, sir. You're the expert.
No, I think all of us are on the same page. No, if you're talking of egg allergy, it is no longer considered a contraindication to giving flu vaccine. If there is a definite allergy, you will consider giving the vaccine only under situation where you can take care of any contingency, like you can take care of maybe in the hospital setting. But to the best of my knowledge, there is no absolute contraindication. Maybe the other two can contribute.
If
Yeah.
there is a documented hypersensitivity reaction like anaphylaxis, which is documented after a flu vaccine, we will be very, very cautious. Since this is not an absolute must vaccine, I think the person should refrain from getting further flu vaccines. If the reaction is as big as an anaphylaxis, they shouldn't go for further vaccines. And the so-called the link between the egg allergy and this doesn't hold good anymore, according to the latest studies.
Absolutely. CDC guidelines do not even entertain the possibility of
Yeah.
allergy with flu vaccine. Yeah.
Thank you very much, sir. I mean, it was a lovely session. I mean, lovely, case discussions were very, very interesting, sir. I'm sure the audience has benefited. Thanks, Dr. Adil. Thanks, Dr. Somshekhar. It was a lovely session. I'm sure we'll have a similar session tomorrow. Thanks, marketing
Thank you,
team.
Prakash.
Thank you, sir.
Sir.
It was a lovely
Thank you,
session.
Anil
I'm
dear.
sure the audience
Thank you,
has
sir.
benefited.
Thank you. I think both the panelists gave
Sure.
very crisp and very
Yes,
Very nice.
lovely,
to
lovely.
the point
To the
answers,
point.
and that made
And
it so
absolutely
excellent.
practical questions. I'm sure the pediatricians have, seen these questions.
Yeah.
Thanks all of you for
Thank you.
taking time from your schedule and attending this. Thanks marketing team and sales team Hitro for coordinating. Thank you IT team for your IT support. Thanks all of you. Sir, we can sign off, sir.
Thank you.
Thank you.
Thank you so
Thank
much.
you all.
I wish you very
Good day,
pleasant.
good day, good day.
Thank you. Good day.